All right, without further ado, we will jump into the digestive system. So, the digestive system, you kind of would think that it's not going to be a super long chapter just because I feel like it doesn't get a ton of attention in anatomy and physiology. But the digestive system that we really focus a lot of our attention on we just think of like the large intestine or the stomach. That's really, I think, that gets the most maybe media hype for health disorders, if there is media hype related to health disorders. We don't really pay as much attention to maybe the pancreas or salivary glands or even the liver. So it is a hefty chapter just because there's a lot of different things that we have to talk about. And a lot of the disorders, or at least a few of the disorders we're going to talk about, are really outside of the stomach and the large intestine. Don't worry, the large intestine has tons of disorders that we're going to go over, but we're going to spend time talking about hepatitis and cirrhosis, and we're going to talk about gallstones and pancreatic involvement. And we'll spend time talking about acid reflux, heartburn. So taking things like omeprazole. My dad's been on omeprazole for way too long. So more dad stories, I know. We'll get to them as we go here. So without further ado, I would like to jump into a review. So I know that you're going through the digestive system at the same time that we are covering this in A&P. You're doing it, I'm sorry, yes, you're covering it in A&P at the same time as we're going over it in Patho, but I don't think it's a bad idea just to kind of review where we're at and the important things that you will make sure to have to kind of bone up on for this chapter. So the first thing we're just going to kind of do is basic anatomical review, and then we'll follow it with some very high level function overview. This isn't going to be super in-depth physiology because we'll talk about that when we get to each of the disorders, how the physiology is essentially going wrong, for lack of better term. So what is your digestive system ultimately for? Basically processing, breaking down what you take into your body and chemically breaking it up. So we talk about mechanical digestion, the chewing, the churning, the peristaltic waves, but ultimately it's really, really about the chemical destruction of the larger molecules into smaller packages or pieces that can be absorbed by transporters that line your digestive tract. Specifically, you get the most absorption in the small intestine and some in the large, but we'll get to all of that. So, anatomical review. I'm not going to spend a ton of time on this, but everything here we're essentially going to talk about at some point. So notice that along with the anatomy, I have listed just really, really basic high-level functions. So make sure you're familiar with this in your own personal studies. So let's talk about some of the structures in a little bit more detail. Not all of them, but I really want to kind of highlight some structures that we see pathophysiology in rather than just, kind of going over the board, if you will, or a poster per se of what all the structures would be. So the gut wall. The gut wall is kind of the unsung hero of the digestive system. The gut wall is made up of two layers. It's got a mucosal layer, and then it's got the layer directly beneath or deep to that called the submucosal layer. So the mucosal layer is consistent of epithelial tissue. It's important that it has epithelial tissue because that tissue is able to, it acts as a protective barrier. It's very similar to the epithelium that you find on your skin that protects you from the outside world. The only real difference between the skin epithelium and your gut epithelium is there's special mucus-producing cells. They're called goblet cells. They're called goblet cells because they're really narrow at one end and then they widen at the top like a goblet, like a wine glass. And the widening part at the end is because there's a structure in there that's just basically a mucus-producing factory. And these cells just basically spew out constant levels, high levels of mucus. Now, the next layer deep to the mucosal layer is called the submucosa, and it's largely connective tissue. So you're going to see blood vessels, nerves, you're going to see some glands, not a ton, and then you're going to see things that are like fibrous, structural. It's going to be just a lot of just tissue infrastructure to give the gut the architecture that it needs. The gut wall also has two different layers of muscle. It has a circular layer and a longitudinal layer. It's really important because a circular layer can constrict and squeeze and help push the bolus of food or chyme, or we'll talk about those terms in a moment, along the digestive tract, and the longitudinal layer is going to help give it, help push it as well, but it's mainly going to give it structural support, and it's going to support the peristaltic waves, but not be propulsive in its action. And then finally, the outermost layer of the gut wall is the serosa, and that term should be familiar to you. We see a lot of serosa layers surrounding organs, and it's just basically the outer fibrous sac that holds everything in place and acts as a protective layer. So switching, kind of going into the mouth, and we'll work kind of top to bottom in the body. Your oral cavity is really important because digestion begins in the mouth. I'm going to say it again real loud so everybody in the back can hear. Digestion begins in the mouth. So you start with both chemical and physical breakdown of food. So you get chemical breakdown of food with enzymes that are in your saliva. You get breakdown of carbohydrates from amylases, and then you have a lipase that comes from the salivary gland underneath your tongue. It's a lingual lipase that starts to very rudimentarily break down fats. You don't get a ton of fat breakdown in the beginning, but you get more and more in the small intestine. But we'll talk about that later. And then chewing is the mechanical destruction. It's the mashing and the gnawing of food into small bits, and this is called mastication. So as you take food from your plate in front of you and you chew it up, it's no longer called food. There's several different name changes. Essentially, it's food in and it's food out when you release it from your body, but we have different name changes for what happens as it's going through the body. Once you have adequately chewed up your food and you're preparing to swallow it and propel it down your esophagus, it's no longer referred to as food. It is now called a bolus, meaning like a lump or a mass of something like a liquid or a solid. Your pharynx is going to be the region, it's basically your throat. So you have your oropharynx and your nasopharynx. Ideally, you don't want any food in your nasopharynx or you'll send it out your nose. Your oropharynx is the basically region of your throat directly behind your or posterior to your tongue. And this is where the swallowing or the degglutination reflex is initiated. Once you propel the bolus of food past your soft palate, you begin this swallowing reflex that becomes autonomic. So what am I talking about here? Let me get my mouse. Oh, sorry about that. Very sensitive. So you have your hard palate is up, what you can kind of feel if you all take your tongue and press it to the roof of your mouth, you are feeling that. And it often has ridges. When you get past the region where there are ridges, get to a smoother section, this is your soft palate, and your soft palate is going to terminate in the uvula. Once you are propelling food, your tongue is going to push upwards towards the roof of your mouth, and you're going to push that bolus towards the soft palate and past the uvula, and that's when you initiate that autonomic response that you really aren't in control of anymore. You just begin to swallow. So this again just kind of reviews what I just said, but in a little bit more detail. The swallowing reflex is the soft palate by muscles in your face is actually lifted upwards. Your vocal cords are going to be what's called approximated, so they kind of shift forward a little bit. So if you ever, so next time you swallow, put your hand on your neck where you feel the vibrations when you're speaking, and watch what or feel what happens when you swallow. So you kind of feel a push forward and up. And that's basically movement of the vocal cords because the esophagus has to distend somewhat to allow the food to propel southward, for lack of a better term. So the epiglottis is that little flap of tissue that's going to cover the larynx to prevent food from going into your respiratory system. You cannot breathe and swallow at the same time. If for some reason that does happen, you aspirate and you end up with a liquid, generally, sometimes a solid particulate that can go down in your respiratory tract and it can be dangerous. The bolus of food, once it's propelled in the esophagus, you are really no longer in control of, as it has peristaltic waves of circular muscles that are squeezing the food down to your stomach, kind of like squeezing a tube of toothpaste. Once food gets to the stomach, you have to remember the stomach is divided into two regions. You have the big floppy bag is the fundus. It's the more superior portion. Then you have the muscular grinder at the bottom, or the inferior portion that is attached to the duodenum, or the first segment of the small intestine. The stomach itself has 3 layers of smooth muscle that are responsible for mixing and churning of your food. So the bolus that comes in gets basically smashed around, and it's important because as your stomach is grinding and mashing it together, it's intermixing stomach contents with hydrochloric acid that's being secreted from your stomach, as well as enzymes that are being secreted from your stomach. So hydrochloric acid is really important because the hydrochloric acid is going to activate an enzyme called pepsinogen. You know that pepsinogen is an inactive precursor because it has the -ogen on the end. Any word you see with -ogen, this is common in human biology, is an inactive precursor. Hydrochloric acid basically cleaves the bond that holds the precursor cap in place, and you're removing the -ogen portion, for lack of a better term, and then you have active pepsin. And pepsin is going to break down large proteins into either small chain amino acids or individual amino acids. So the hydrochloric acid itself will also help denature or unwind some of the larger molecules that you have eaten into smaller bits that can be more easily absorbed in your small intestine. Your stomach also produces a hormone called intrinsic factor. We talked about this hugely when we were talking about the blood chapter. So without intrinsic factor, you cannot absorb B12. And if you don't have B12, you have a lot of problems with respect to production of red blood cells. So it's really, really important that your stomach make this. And if it doesn't, we talked about B12 supplements and shots and things like that. So once basically the bolus of food that has gone to your stomach and it's intermixed with all of the enzymes and acid and more mucus, you have these mucosal secreting goblet cells all over your stomach. Like every 5 or 6 cells in the lining is a goblet cell producing more and more and more mucus. You want everything you've eaten to be kind of nice and slimy so it can be easily propelled. You have to remember that you're going into the small and the large intestine next, and they're very, very long tube structures, and you want it to be well lubricated so it doesn't get stuck along the way. So at this point, we have the food ready to leave the stomach, or the bolus rather, and it's going to change names. At the point that it's getting ready to exit the stomach through the pyloric sphincter, that's an important structure to know, and go into the duodenum, the first segment of the small intestine, it's going to be now called chyme. So we've had food, we've had a bolus, now we've had chyme. And absorption of all small lipid molecules, some can happen in the stomach, but mainly it happens in the small intestine. But before we jump to the small intestine, go back a few slides and look anatomically at the diagram. We have a couple other accessory structures that we should talk about. We're going to talk about the liver, we'll talk about the pancreas, and we'll talk about the gallbladder, are kind of right in this region. So we really should hit those first. Your liver has so many different functions in your body. It's really a giant metabolic factory in your body. So it gets blood from the hepatic portal vein. And why this is so important, it's kind of like closed circuit circulation. Like they say, you hear about like closed circuit TV. It's kind of like that with your blood. You get a direct blood supply that comes from your small intestine and goes to the liver. So everything you're absorbing, all nutrients, maybe oral drugs, Tylenol, what have you, any prescription medications, everything goes to the liver first. And this is really important because things like fat, when they hit the liver is kind of like the post office, and it kind of decides where each package is going to go. So certain fats are going to be retained and stored, certain fats are going to be used for manufacture of hormones, and certain fats are going to be sent out for other purposes in your body. Well, carbohydrates, it's really the same thing, because your liver is responsible for storing basically excessive carbohydrates as glycogen. So if you take in too many carbohydrates in your body, your liver stores them to be used later. Because let's say you go into a fasting period where you're not going to eat much. Well, at that point, you would need to call on your glycogen stores so you have enough sugar to keep your blood sugar at an adequate level to sustain life. Now, your muscles can also store glycogen, but your muscles only store enough glycogen for each muscle themselves to use. They don't help out with maintaining blood glucose levels for your whole body. Your liver does that alone. Your liver is also really important for metabolizing and clearing waste products from your body. It's important for clearing out dead, old, defunct red blood cells. Your spleen helps with this too, but your liver is kind of the air traffic controller in the deal. And then finally, your liver makes bile, and bile is required for absorption of fat. So your pancreas has two functions. It has an endocrine and an exocrine function. I think we've talked about the endocrine function quite a bit already. Hormone secretion, insulin, glucagon, somatostatin, peptide YY. There's a few others that we've covered. But we're going to focus on the exocrine function. Remember, endo means hormone. Exo basically means digestive secretory contents. So your pancreas makes very specific enzymes, and it can make some electrolytes. We'll talk about that in a minute. So the enzymes that I really, really want you to focus on is pancreatic amylase here. Pancreatic amylase is manufactured by the pancreas in special cells called acinar, A-C-I-N-A-R. It's a Greek word that means berry-like cluster because they form basically in these little circular grouping of cells, and they produce amylase, and they dump it into the duodenum. It goes down a duct, a tube, and then it dumps into the duodenum and intermixes with the food, the chyme rather, that's leaving the stomach and it going to the small intestine. You also are releasing trypsin and chymotrypsin, and these are both really, really important for the breakdown of protein. So most protein digestion happens in the stomach, but trypsin and chymotrypsin are really important for the final absorption of protein and final breakdown if there's any amino acids that aren't singular in that first segment of your small intestine. And then, of course, ribonuclease is important because it's going to break down DNA and RNA, but we're not going to spend as much time talking about that. So I also have highlighted here that your pancreas makes electrolytes. So, and we're not necessarily talking about like electrolytes that maybe you hear about like with Gatorade, you know, the sodium, the potassium. What's being made is bicarbonate ions. The reason this is super, super important is because your stomach, with no food in it, has a pH with that hydrochloric acid, closer to 1. So in the pH realm of the world, 0 is the most acidic, so high acid content, lots of acid. And 14 is the most basic you can have any pH. So you have to remember that the pH of like 0 or 1 could burn, it could destroy, it could eat holes in things. That's dangerous. So when food enters your stomach, well, first of all, your stomach has a huge mucus lining to protect itself from being auto-digested by your enzymes, but you have food enter the stomach and the pH only rises to about 3, from 1 to about 3, because there's so much acid. Well, 3 isn't terribly acidic. 3 is like the pH of orange juice. But still, that's a high acid content. Have you ever sliced a lemon or something with a cut on your finger? You sure remembered you had that cut on your finger because the acid is causing the burn. Well, think about how sensitive the duodenum of your small intestine is. You want to make sure that it's not too acidic so you don't burn and hurt or destroy it. So all the bicarbonate ions that your pancreas makes are very, very, very basic. And then you mix them with the chyme and you bring that chyme from a pH of 3 to about a pH of 6.5 to about 6.8. So now it becomes much closer to normal physiology, which is 7.4. So now the chyme, as it enters your duodenum, is more basic and it's now not going to damage you. Plus, you have to remember that all these enzymes here that I've listed, they would all be destroyed in a very acidic environment. They need to be closer to human physiology to be able to be functional. So raising it anywhere from 6.5 to 6.8 allows these enzymes to work. So moving on, we'll talk about your small intestine. It's divided into 3 regions. The duodenum, I know it's spelled duodenum. It is pronounced duodenum. the jejunum, and the ileum. Now, the small intestine is longer than the large intestine, but it's called the small intestine because the diameter of the tube, the diameter of the actual intestine itself, is smaller. The large intestine has a larger diameter. The small intestine also has tons of folds or little finger-like projections called villi. They're really, really important because they increase the surface area. You could absorb more things per every square inch if you have all this extra surface area hanging around. So it's also the small intestine is a huge area for your body to make more mucus. You are making mucus from beginning to end in your digestive tract. You also make other enzymes, enterokinase, peptidases. Peptidase is going to break down more peptides or proteins. Nucleosidases is going to break down nuclear material. Because remember, you're eating things that have a nucleus. You're eating plants. Plant cells have nuclei. If you're not vegetarian, you're eating animal cells. They all have nuclei. So you got to break down that material so it can be in small enough bits to be absorbed. You also are releasing lipases, which are going to break down lipids. You're going to be releasing a sucrase, which can break down sucrose. Maltase breaks down maltose. Lactase breaks down lactose. And cholecystokinin is also referred to as CCK. Cholecystokinin is a mouthful to say, so it's abbreviated CCK. And it's a hormone that actually helps slow down your digestive tract so you can have adequate time to absorb all the nutrients. So this is a basic high-level overview of what all of the enzymes do, or this isn't even all of them, but it's main ones. I don't think you necessarily need to memorize these. The ones that I have mentioned specifically, I would just be familiar with. I don't really think that flashcards of this would be necessary, but again, just read it through and just have a general understanding of where each comes from and what does what. Keep it simple. All right, so moving on to the large intestine. The large intestine, remember, it's shorter in length but bigger in diameter. It has special like globs of tissue that are like immune cells, kind of. It's all lymphatic. So it's really important to remember that your immune system is surrounding, it's all over basically in these globs of tissue of your whole digestive tract, because remember what you're eating, taking in from the outside world, it's all foreign material and it could make you ill. So your immune system's watching your digestive tract like a hawk. The globs of tissue that do this function in your large intestine are called Peyer's patches. You also have a ton of bacteria that live in your colon, your large intestine. Quick fun fact of the day, you know I love these. 1/3 of all your fecal matter, so 1/3 of all the poop, guys, is dead bacteria. So, and this is important because when bacteria get old and defunct, you slough them off and new bacteria take their place. It's really important to have normal flora. It's really important to have this set of bacteria that lives in your colon. There's a couple of reasons. Well, first being, so have you ever tried to like get a hotel on vacation and didn't know there was like an event happening in the city you wanted to visit, like a big concert or some other like social gathering? I'm thinking like a NASCAR or I don't know, but something you wanted to go somewhere and you wanted to get a hotel room and they were booked. And you're like, okay, fine. I'll call the next hotel and they're booked. You call the next hotel and they're booked. Well, you can't get a room to save your life. So you know what? You're just not going to go there. You will change your vacation plans and you will go somewhere else. That's how it works with pathogens. A pathogen wants to come and inhabit somewhere in your digestive system, and they're like, well, I can't land. If a pathogen's going to get in your body, it has to physically land on your body and be able to, this is the important step, infiltrate. It has to be on you long enough to squeeze past your defensive cells, squeeze through the epithelium, and get into your blood. That's the bottom line of it. So if there's no room at the inn, if all the hotel rooms are booked, then the pathogen can't book a room and stay. So if you have good, healthy bacteria all over your gut, which by the way, you have bacteria all over your body. You have a ton of bacteria that live in your colon. You have bacteria that live in your hair and your scalp, bacteria all over your face and your ears, up your nose and your mouth. Gross, right? Nope, it's not. It makes you healthy. These are good bacteria that live in a healthy symbiotic relationship with you. So keep in mind that you want to keep your normal flora happy and healthy by feeding them appropriately. You hear all this hype about probiotics and prebiotics. Well, it's good and it's relevant. So other people ask, well, how can I get probiotics? Taking probiotic pills, they're dead. Yes, they might be in spore form and they might be able to regrow, but they have to get past that acid in your stomach. The best way to do this is to eat live cultures. Cottage cheese, yogurt, sour cream, anything that has bacteria that's been used to cultivate it where it's still alive and it could potentially spoil. So eat a yogurt every day. Do you need Activia? So I don't hate Jamie Lee Curtis. She's the spokesperson, for those of you who don't know. But is it really important to have Activia that has Bifidus regularis, which isn't really even the name of a real bacterium? No. You just need something with live cultures. Have a yogurt every day. Kroger brand, you know, I support my local Kroger. Well, I'm required to by law. My significant other, you know. Anyways, my point is that having live cultures keeps your gut healthy. Okay, I'm off my soapbox and I'm back to the large intestine. So here's another interesting factoid. Until this point, all of the chyme that has been flowing through your system is really, really watery, and it's not actually solid. Your small intestine is hugely responsible for absorption of nutrients, but your large intestine is responsible for absorption of water and vitamins. So this is the first time where you're pulling the water out and you're actually making a solid material. The material that leaves your body, fecal matter, is not true fecal matter until it gets the large intestine and the water is removed. Okay, so your digestive system is controlled by a balance between your parasympathetics and your sympathetics, just like the rest of your body. We really talk about the sympathetics driving that fight or flight response. It amps you up, it gets you going, you can run from a tiger. It turns everything in your body from volume 10 to volume 100, except your digestive tract. Your digestive tract is your parasympathetic control. We say sympathetics are fight or flight, parasympathetics are rest and digest. So if your parasympathetics get activated, you will have a higher activation of your gut. Your stomach's going to churn more peristaltic action, more ability to propel those mass movements of the fecal matter through your large intestine. And the cranial nerve, largely responsible for this. I know, cranial nerve, right? We're talking about your head. Your cranial nerve number 10, your vagus nerve, spans, basically it starts at your brain and goes all the way to your rectum. All right, so here's just a review of some other controls. We're not really going to cover these in major details. I talked about cholecystokinin. This is really important. And then we talked about your sympathetics and parasympathetics. Secretin and gastrin are also important too. But again, I would just keep this as kind of a brief review. All right, a little bit more about some neuro and hormonal controls. You have your glossopharyngeal nerve, that's cranial nerve or facial nerve rather. You have your facial nerve, and your glossopharyngeal nerve. It's two nerves. Your cranial nerve 7 and 9. I should have highlighted this one. I didn't. I apologize. And basically, these are the ones that are going to be supplying the nervous input to all 3 sets of salivary glands. They're going to control when you salivate and what's in the salivary contents. Is it going to be water? Is it going to be mucus? Is it going to have enzymes? These 2 nerves drive all 3 sets of salivary glands. Here's an interesting one. As soon as food hits your stomach begins to stretch. When it stretches, mechanical receptors are activated and instantly activate your parasympathetic nervous system, and then you get the higher increase of mixing and churning. So as soon as the stomach stretches, the churning is activated through this mechanism. So interesting. It takes your stomach anywhere from 2 to 6 hours to empty after you eat. So you can eat, if you're going really quick, in like 15-20 minutes. But it can take 2 to 6 hours. This is why it's important to think about how much you're consuming and how often you're consuming. So the reason 2 to 6 hours is the window is because do you eat 3 large meals a day? Do you eat maybe 5 small meals a day? So it really depends. The less you eat, the quicker it empties. The more you eat, the longer it empties. Like, so think back to last Thanksgiving. You ate a ton of food, and then everybody wants to come have pie later, and you're like, I don't know if I can squeeze another bite. But it's Thanksgiving, so you have pie because it's required by law. And if you're me, you try to cut like small slices and have a piece of all of the pies. But that's just me. Anyways, we can talk about more of that later. I enjoy pie. So when food is in the intestine, you get something called the enterogastric reflex. And this works with that hormone called cholecystokinin. And basically, as soon as food is leaving the stomach through the pyloric sphincter, it goes into the duodenum and it sends a signal to your brain to then decrease your parasympathetics to slow things down. Because the longer food sits in your small intestine, or really its chyme at that point, the more efficiently you can extract nutrients. All right, so here's a couple of those other hormones that we only briefly talked about in the last slide. So it has 2 stars, different colors. It must be important. Hint, hint, these are actually the colors of my alma mater where I did my undergrad at. So I don't know, just interesting. Gastrin is important. Gastrin comes from the mucosal cells in the stomach, and it comes as soon as the stomach stretches. Gastrin is going to increase motility. It's going to help things speed up a little bit, where cholecystokinin, my other blue arrow at the bottom, is going to slow things down. So food first hitting the stomach sends things into overdrive. Food first hitting the small intestine says, nah, we're just going to slow down. All right. So what happens with all of your macromolecules? You have carbohydrates, proteins, and lipids. Who does what and what happens where? Carbohydrate digestion begins in the mouth, mechanically and chemically. Chemically, you can't lose sight of that because you have all of the enzymes that are intermixed in your saliva. So once the food, or it's a bolus at this point, travels through your esophagus and hits your stomach, 0 more digestion happens in the stomach of carbohydrates. However, asterisk, once food makes it from the stomach to the small intestine, the carbohydrates begin to be digested again. So they kind of get phase 1, phase 2. Protein digestion starts in the stomach. The vast majority of it happens in the stomach, and it does continue in the small intestine. However, only a really tiny amount, and really only in that first segment. Lipids, so here's what's interesting. Lipids have to get mechanically broken down by chewing, and they have to get chemically broken down by lipases, but they cannot be directly absorbed. They're wrapped up in something called bile. It's called emulsification. Bile are little tiny molecules that wrap around fat droplets, kind of like bubbles, and they allow them to be absorbed into the bloodstream. Fat obviously is fat, and it doesn't like to intermix with water. It's like the Italian dressing phenomenon. You can shake that bottle of Italian dressing, but if you let it hang out long enough, it begins to separate. Oil and water don't mix. So you have to wrap all the fat in specialized molecules called bile in order for them to be absorbed. And those specialized little bubbles are called chylomicrons. So some vitamins you can only absorb with fat. Vitamins A, D, E, and K do not get directly absorbed. There's no special transporter in your body to take them in. They actually jump into those bubbles or those chylomicrons with the fat and are absorbed into your body that way. The water-soluble vitamins, all of the vitamin Bs and vitamin C, can directly go into the bloodstream and they can float around in your blood without being damaged. So electrolytes, we're talking about larger molecules like sodium and chloride, well, salt rather, potassium, some bicarbonate. Some of them can float freely. Some of them hitch a ride with transporters. But most electrolytes are going to be absorbed directly via your small intestine. Drugs that you take, like Tylenol or a prescription or ibuprofen or what have you, are all absorbed in the small intestine. They don't really get absorbed other places. They can, depending, some go in the stomach, like aspirin, the salicylic acid, but most, like the vast majority, happen via the small intestine. All right, water. So water is absorbed in your body via osmosis. You have about 700 milliliters of water that goes into the digestive tract from the rest of your body. So you're getting a pouring in of liquids every day. So that's so for references, it's almost a full bottle of wine that your body puts into your digestive tract. This is not what you're taking in. You get about 2,300 milliliters that you take in food and fluids. That's little more than a 2-liter bottle of pop. Here's the really fun part. You only lose about 50 to 200 mils in your fecal matter. So look at, do you have a bottle of water near you? Look, seriously, next time you have a bottle of water, look at it. I have a bottle of water near me. It's just an Aquafina bottle. It's got 17 ounces and 502.8 milliliters. So what I'm looking at is it'd be half of that bottle would be leaving via the fecal matter. And that's with all of bowel movements combined. Pretty wild that you only lose that much water via your fecal matter. So it really shows you how solid fecal matter is. So here's the other side of it. Where's all the water go? Well, that's kidneys. That's another chapter. All right. So now we are going to take well, this would be a good place to break. How about that? So we'll take a break, and I'm going to go see if you have any questions. All right, so in the way of digestive system disorders, we are going to just, before we get too deep into it, I think it would behoove us to really discuss basic tests. Like, how do we even examine the GI tract in general? Well, you can do so with radiography. So this would be, and I'll talk a little bit about CT and MRI, but this is thinking more with an X-ray. So there's kind of a flip side to this, because with an X-ray, you're really only looking at bones. A lot of your organs are not dense enough to examine. So sometimes you can give somebody a special liquid, it's usually full of barium, that your organs absorb really well and makes them basically shiny, for lack of a better term, and they can be picked up by X-ray. So you could also do an ultrasound. Ultrasound is good for looking at topography. Topography is usually a term we use in geography, but it's in reference to like the bumps and lumps and the terrain of what things look like. And here, basically, you are looking to see if something's out of place. Is there a growth, or is there a distension? Is something there that shouldn't be? CTs and MRIs are going to give you your good pictures. Remember, MRIs are more high definition, but CTs are not magnetic. Let's see here. We also have endoscopy. This one's fascinating. Fiber optic endoscopy, it's kind of like a snake light, for lack of a better term, that they would put in your mouth and put down your throat so they could look around in your esophagus and in your stomach. Now, the other side of it is you could have a sigmoidoscopy or a colonoscopy, and it's basically the same scope, but it goes in from your rectum and would look at your rectum or your colon, usually your sigmoid colon, and maybe a little bit past. But basically what in a colonoscopy they're looking for is if there's any polyps, which would be extra growths, or maybe a parasite or bleeding or indication that there's some sort of abnormality. So there's a camera, and then there's usually, I would say, it's like a set of scissors, but it's not exactly. It's like laser powered usually. So it can kind of just go in and cauterize as it cuts and remove a polyp from your intestine if there is one. So laboratory analysis can be done with blood or stool. So this is the first time where we're really seeing extra fluid be examined. So we see these with our pets all the time, looking for parasites in their fecal matter, but you can do it in people too. So tapeworm is something we really think of like in maybe cows or sheep, maybe even fish, but people can get tapeworm too. And sometimes what you're looking for in fecal matter isn't necessarily the live parasite, because that's hard to detect sometimes, but sometimes you're looking for their eggs. You're also looking for blood. If fecal matter turns real dark black, it's an indication there's an internal GI bleed. You could also be looking again for tumors via polyps and seeing if there's something wrong with the internal anatomy that could be causing malabsorption. Blood tests that are done typically look for enzymes or they look for byproducts in the blood that should be being broken down in your GI tract. So how typical GI tract disorders are treated. So we have this new push. It used to be throw a pill at it and the patient will go away. But we've often seen that that can actually cause more problems. So quite often, GI disorders are they are stumbling my words here. They are tried to be treated with diet modification first. Like, for example, people who have celiac disease basically get a lot of inflammation and almost an allergic reaction to gluten. So that being said, if people have a gluten-free diet, they can hopefully suppress all the inflammation. Alcohol can disrupt fat absorption. Alcohol can also dehydrate. So changing alcohol consumption could be a way to treat it. Coffee is full of caffeine, and caffeine can affect your GI tract as well. So again, trying to modify what we're putting into our body might actually modify how the system is acting. One of the biggest complaints with the GI tract is constipation or diarrhea, one of the two. So ways to treat that would be balancing fluid and water intake to make sure there's adequate supplies of both. Stress can actually cause constipation. Stress activates your sympathetics, which is going to clamp down your GI tract and decrease motility. And then sometimes we take drugs, and I'm not necessarily talking about like illicit street drugs, although those can do it too, but I'm talking about like prescription drugs that can affect your GI tract. So they might have one intended purpose, but a side effect might be diarrhea or constipation or intermittent bouts of both. So some drugs that we can use to treat GI disorders would be antacids. This would be something that you could take for heartburn, also called pyrosis. An antiemetic is something like Zofran. Patients who are undergoing chemo or have other underlying issues where they're constantly vomiting. Individuals who struggle to be able to have a bowel movement may take a laxative. Some laxatives work by increasing muscle contraction. Other laxatives work in such a way where they help bring extra water into the GI tract to help kind of make things a little looser so they move along. An enema is a physical flush, and it only really is going to affect the rectum and the sigmoid portion of the colon. It happens if maybe there's not enough liquid in the fecal matter and it can't physically be propelled out. It's because of massive dehydration, it kind of just becomes lodged and immovable, and an enema is going to force water into it. Antidiarrheal medications don't do a lot for liquid, but they basically slow down the peristaltic churnings so the bowel becomes less spastic, and that as a side effect relieves cramps, which is a good thing. So some actual drugs that can be prescribed, so you have sulfonazine. It's an anti-inflammatory and an antibacterial. So quite often people who have inflammatory bowel diseases like ulcerative colitis or Crohn's disease might need to be put on something like this to relieve their pain and spastic bowels. You can also take something called clarithromycin or azithromycin. This is important. It's an antibiotic, and you know it's an antibiotic because it ends in mycin. And it helps get rid of something called Helicobacter pylori. Helicobacter pylori is the #1 bacterium implicated in ulcers. Other bacterium can cause it, but H. pylori is the main culprit. And then you also have sucralfate, and this is a coating agent. This is basically done to enhance maybe not increase mucus, but help make the mucus hardier in your stomach to kind of prevent your acid from destroying or hurting your own stomach tissue itself. So it helps kind of enhance the ability of the mucal layer to be effective. There's some other drugs. These are more classes of drugs rather than names of specific drugs. Anticholinergic drugs. So something that's cholinergic is going to work with acetylcholine. Notice the overlap in words. So if it's anticholinergic, it's going to decrease acetylcholine. It's also going to reduce your parasympathetics. So it's going to slow down your GI. It's going to slow down all of the secretions into and out of. It's going to slow down the speed at which it acts. You also can take something called a histamine 2 agonist. The number 2 is just in reference to the subtype. There's histamine 1, there's histamine 2, so on and so forth. So, and I'm not sure how many there are, but there's 4 or 5. So a histamine antagonist is important because histamine is going to cause agitation and irritation. So, and that actually is important to help get hydrochloric acid and enzymes working. But if you have too much histamine, it can cause acid reflux and cause your sphincters that are at the bottom of your esophagus to malfunction, and you could have stomach acid flare up the wrong way in your esophagus. So the antagonists help stop this. And then proton pumps are important. Proton pumps are what basically generate hydrochloric acid. And if you have too much acid, you can decrease the amount of protons that are part of the manufacture of hydrochloric acid, so you'll have less acid overall. The hydrogen in hydrochloric acid comes from the proton pump. All right, so this is just a high-level overview. Again, treat these as just kind of review them, read them. I don't think you need to commit anything here to like flashcard memory, but it's a good review. All right, so we're going to jump into the upper GI disorders real quick and try to get through those. I know it seems like a long list, but they kind of flow one into the other and they make sense. So we'll start with acid reflux. I'm going to try and work from the superior portion of your GI downwards inferiorly until we reach the junction of the lower GI tract. So gastroesophageal reflux is acid reflux. It's the same thing. So basically what happens is you have a sphincter at the top of your esophagus and a sphincter at the bottom of your esophagus. And these sphincters are closed when you're not eating. When you are eating, they open to allow the food, which is the bolus, to go down your esophagus. And the lower esophageal sphincter, that is basically the junction between your esophagus and your stomach, needs to stay closed all the time, except when letting food in to prevent stomach acid from flaring backwards up the wrong way and causing the burning, painful sensation in your throat. So when you have malfunction of this sphincter, you quite often experience acid reflux. So a couple of things can cause the sphincter to malfunction. Too much caffeine, things that are really high in fat, especially like saturated or trans fats, spicy foods. I love spicy foods. Have you ever gotten like massive heartburn after a really, really spicy meal? Yep, me too. And that it's because all the capsaicin essentially that makes the spice can kind of mess with the effectiveness of that sphincter. Excessive alcohol intake can cause acid reflux. So alcoholics quite often have chronic acid reflux. Smoking. So smoking actually causes relaxation of the muscles, and your sphincter just doesn't close, or the LES rather, doesn't close as tight as it should. And then certain medications that we are prescribed have unwanted side effects. All right, so back to H. pylori. H. pylori is really, again, that #1 implicated bacteria for stomach ulcers. Stomach ulcers are called peptic ulcers, and duodenal ulcers are going to be the ones in your small intestine. So typically, most ulcers are going to occur in the proximal duodenum, which is the very, very beginning of the duodenum, or the distal portion of the antrum of the stomach, which is that last section, that muscular grinder of the stomach, before it reaches the duodenum. So really in that region, so either the end of the stomach or the beginning of the small intestine, is where you see most duodenal ulcers. So typically ulcers are going to start as just breakdown of the mucosal layer. So the mucus that's protecting the lining, that just starts to kind of get eroded away. And then eventually it starts to eat and destroy actual stomach tissue. And if it completely eats a physical hole, it's called perforation, like you're popping a hole. So so my cartoon shows typical areas. So here's my mouse. There's your esophagus. This would be your lower esophageal sphincter. So you might see, typically you would see ulcers. This would be the distal portion of the antrum or the proximal portion of the duodenum. You could also see it in the lesser curvature of the stomach, or along the inferior portion of the stomach as well. But again, more common here and here. So here you see little ulcers. These are these little black points. It's just bleeding in the stomach, little scabbed over portions. This is a large ulcer right here, and it's bleeding. So it's completely eaten all the way through the mucus, and it's beginning to, and it is eating through the stomach lining, because you know that because it's actually eaten into a blood vessel and you're getting blood pouring now into the stomach. So there are certain things in our life that can predispose us for ulcers, and that's not great. So if you are on a drug that might decrease your mucosal barrier, then that's going to predispose you for possible ulcers later. Also, excessive glucocorticoid secretion. So glucocorticoids, again, come from your adrenal glands. They're steroids. We upregulate them in times of stress, fight or flight, high sympathetics. So if you're feeling really, really stressed out right now, you have lots of cortisol in your body, and that can be suppressing mucus supply. Also, if you're on steroids or some other type of glucocorticoid derived medication, other things that can predispose you for ulcer formation is chronic taking of things like aspirin, the salicylic acid, NSAIDs, ibuprofen. All of these things decrease mucus presence. And then alcohol. Alcohol basically, so we use alcohol in cleaning supplies because it disrupts fat. Okay, so your mucus definitely is not fat, but the way it's constructed isn't that different, and it can disrupt the mucus molecules from being sticky to each other. So a couple other things we have to talk about is if you have something called an increased acid pepsin secretion. So pepsin, again, is a really, really important enzyme for breaking down protein, and it requires acid to be active. So this is also going to cause an increase in gastrin secretion. Remember that hormone we talked about? And it's going to increase vagal stimulation. Your vagus is that cranial nerve number 10. And as you have increased vagal stimulation, you're going to have extra propulsive movements and possibly spastic bowels. So interestingly, you're going to end up with an increased number of cells overall that are going to produce acid and pepsin and lead to this excessive GI propulsion. This seems to have genetic underpinnings. So what that means is if your parents have it, you might have it too. Alcohol, caffeine, and spicy foods can also increase the production of this acid pepsin. All right, so a couple complications of having ulcers. Hemorrhage, that's bleeding out. You saw from my picture. If you erode deep enough, you're going to go into a blood supply and you're going to have a hemorrhage. You're going to start to bleed and get blood intermixed with your food, and you'll end up with blood kind of throughout the entire duration of your GI tract, and this can decrease your overall blood supply in your body. This can lead to anemia. It's pretty dangerous. Perforation was what I already mentioned, where the ulcer, that bacteria, completely eats solid all the way through the organ and pops a hole in it. So now you risk having food contents, which, remember, it's now things you've eaten, which it's bolus becoming chyme intermixed with enzymes, and who knows what you ate. What if there's bacteria in there? You could be leaking this into your peritoneal cavity. There's also a risk of having a physical obstruction, because you have to think the bacterial infection of the H. pylori might be relapsing and remitting. So you might, for a while, have a relief from it. Maybe you've taken antibiotics and you drive your H. pylori infection down, but you don't get rid of it. Your stomach starts to heal. As it starts to heal, scar tissue forms. Anytime there's a laceration, scar tissue forms. So then, if you turn around and the bacterial infection rears its ugly head again, then all of a sudden you're going to form another hole, maybe another perforation, and if it heals again, more scar tissue. So you see, it's kind of a vicious cycle here. And in that vicious cycle, more and more and more scar tissue. And what if you completely plug up the antrum of your stomach so you can no longer pass food? That would be dangerous as well. So some signs and symptoms would be burning. You're going to get a radiating pain, and it typically will happen after a meal, as the stomach contents are emptying and going from the stomach to the duodenum. So some diagnostic tests would be a fiber optic endoscopy. That's the one that goes through your mouth and goes down and looks around with a camera. The barium X-ray is what I was talking about before. It's the radiography with the marker that you can take. It's a liquid. There's, I would say, close to a liter and a half of it you would have to drink. And sometimes when they do endoscopies, they could be taking pieces of your stomach lining to examine it under a microscope. Treatment is really going to be antibacterials, proton pump inhibitors, and anti-inflammatories to reduce the pain and swelling. So what you are looking at now is not so much the typical H. pylori ulcer. This is now going to be a stress ulcer. So stress ulcers can be really derived from the increase in sympathetic nerve activity due to constant fight or flight. This is going to be associated with trauma or maybe systemic problems. Maybe you have another underlying disorder that could be leading to this. Typically very rapid to onset. So you can go from perfectly fine to lots and lots of little tiny stress ulcers very, very quickly. They're typically almost all gastric, hardly ever in the duodenum. And the first indicator is going to be the blood that's going to be being leaked into your chyme content, so it can be detected in the stool. Usually turns the stool very, very dark, maybe even black. And there's going to be a burning, radiating pain in the inferior stomach regions. So kind of leaving the stomach now, we're moving further south or further inferior, if you will. So gallstones. So I don't know if any of you have ever had gallstones. I have, and they are terrible. So I put the pronunciation on here because I think that when sometimes people look at this word, they say, wow, that's a mouthful. We're just going to call them gallstones, which is exactly what they are, but they are cholelithiasis. And if you say either, people will understand medically, but I want you to know how to pronounce the medical term. They are solid, like little rocks. They're called calculi, and they're made up of bile and actual salt, like either sodium or usually calcium chloride. Vast majority is calcium chloride. You can also develop something called cholecystis, and this is basically chronic inflammation of the gallbladder and the cystic duct. I'll show you what this looks like in a slide or so. Then you can also develop something called cholangitis, and this is inflammation of just bile ducts in general. And then you kind of have everything all put together, which gives you complete obstruction of the biliary tract by the gallstones. So here is what I mean. So, okay, just to give you a little anatomy or topography, your liver here, your gallbladder. Now, the way this picture is being shown to you is not anatomically accurate. Your gallbladder does not sit anterior to your liver. It's actually directly inferior. So if you put your hand out in front of you and kind of bend it a little, the top of your knuckles would be this lump right here in your liver, directly on the underside, and where your palm is, maybe about where your middle finger and your palm is where your gallbladder would be. And it is green, and it's because the bile is green, and it stores all of the bile that the liver makes. So as soon as you eat a meal, as soon as your stomach stretches, the gallbladder contracts and squirts all of its bile, and it goes down the cystic duct, it dumps into the bile duct, it then merges with the pancreatic duct, and then goes into the duodenum, so it can intermix with all of the chyme that is in your duodenum to help emulsify and absorb the fat. So here's where the problems come in. You can get a gallbladder full of stones, which would prevent storage of bile. You could get blockage of the cystic duct with a stone. You could get blockage of the common bile duct with a stone, or you could get blockage of the pancreatic duct with a stone. So each of them have their own complication. You could even potentially have stones go back up into the liver, but that's less common. So if you have blockage of the gallbladder, you're not going to be able to release bile, and it's going to create a back pressure and pain. If you have blockage of the bile duct with a stone, you're going to have backup of bile into the gallbladder and backup of bile into the liver and have a back pressure and pain. If you have blockage of your pancreatic duct, you're going to have back up into the gallbladder, the liver, and the pancreas, and have the increased pressure and pain. So it kind of depends where the stone is. You can see how the severity would change. So over here, you can see this is a gallbladder that's been removed from a patient, and it's just chock full of stones. They look like little rocks. The calculi, again, it's hardened bile, and it's combined a lot of the time with calcium salts. It'd be calcium chloride. So it's pretty wild to see these. And to see sometimes a patient will have one or two, sometimes their whole gallbladder will be just chock full. Something like this will cause massive what's called gall attacks, and the pain starts very radiating in the middle of your back, kind of between your shoulder blades, but slightly inferior to your shoulder blades, and can radiate kind of all the way forward and up to your neck. I've had gallstones. It's an incredibly painful thing to undergo. I've been told kidney stones are worse. I've never had a kidney stone, but I can tell you from the gall attacks that I have had, I have actually passed out from the pain. They can be pretty intense. Oops, sorry about that. Small stones usually aren't an issue because they're small enough to just travel down the ducts, and they go into your duodenum and you release them in your fecal matter. The larger the stone is, the greater the risk of obstruction. So risk factors for gallstones. Fascinating. Women are more likely than men. Why is that? Well, skip down to my fourth blue arrow. Estrogen. So taking oral contraceptives can increase your risk even more on top of being a woman. But a lot of it has to do with estrogen. High levels of estrogen in your body seem to promote gallstone formation. Doesn't mean just because you're a woman or just because you're on birth control doesn't mean you're going to get gallstones. It's just a risk factor. There's a statistical linkage between people who have gallstones and the amount of estrogen in their body. There's a high cholesterol. Remember, bile is really important for absorption of fat. So the more trans fat and saturated fats and cholesterol you take in, the more bile you're going to need, and the more cholesterol is just going to be present in your body in general, and the greater risk you're going to be at for forming gallstones. Women who've been pregnant and had twins or triplets, etc., it's called multiparity. So that is a risk factor in and of itself. Again, think about it. What happens when you're pregnant? Your estrogen and progesterone goes through the roof. So again, back to hormones. Alcoholism or general infections of your biliary tract are a risk factor as well. The danger is complete obstruction. With the complete obstruction, you're going to get the radiation of pain simply due to back pressure of the biliary contents building up. It can lead to nausea and vomiting. It doesn't always. I've gotten nauseous, but I've never had to vomit with my gallstone pain. It's usually just been really, really intense radiating pain. If the obstruction is not removed, you can really lead to complete blockage of the liver, which is dangerous because then jaundice can sit in. We'll talk about this shortly when we get to the liver. There's also risk of completely rupturing the bladder. It kind of would just explode due to back pressure. So the one thing I do have to say, though, is if the stone makes its way and can move into the duodenum, then the pressure should subside. Surgical intervention is a really common thing. You just remove the gallbladder completely. The only flip side of this is you no longer can store bile, and usually low-fat diets are recommended because now you have less bile readily available in your body to wrap around and emulsify fat. So jaundice, there's different types of jaundice. There's prehepatic jaundice, intrahepatic jaundice, and posthepatic jaundice. So prehepatic jaundice quite often is the result of excessive destruction of red blood cells. It's basically, you see it with hemolytic anemia. We covered that in the blood chapter, or people who have bad reactions to blood transfusions. There's also intrahepatic jaundice. So this is where the liver itself is being destroyed, either with hepatitis or cirrhosis. And then posthepatic jaundice usually is something that happens with bile or other liver secretions that happen after the liver itself. So this would be obstructions via stones. So this is a really good review chart that just talks about everything we went over. I'm not going to go over it, but I think this would be a good flashcard slide. So since we're talking about jaundice, let's take a minute and talk about bilirubin. So bilirubin is something we hear a lot about, especially in babies. Bilirubin is kind of this yellowish orange compound, and it's really important in breaking down heme. Remember, heme comes from hemoglobin. And this is really important when you're getting rid of waste products like that arise from dead and defunct red blood cells. So as you have dead and defunct red blood cells, then essentially you have to you have to clear them in such a way that the body isn't going to have any toxic substances. The heme gets recycled and reused, and the rest of the waste products essentially go out into your stool. And bilirubin's really important in helping with this. However, bilirubin can be toxic if it itself builds up in your body. You really need to clear the bilirubin out again via your stools. So just a quick review before we continue any further. This is what liver lobules look like. They're these kind of hexagon-shaped structures made up of many individual cells. They have arterial and venous supply, but then they also have a central vein in the middle of every lobule, because what's important here is it drains. Your liver is a huge filter for detoxifying agents in your body. So the vein, remember, is going to carry waste products in general to be cleared out of the body, either via the kidney or the lungs. And so you want to basically drain everything out of the liver. So I want you to notice too, the green here are hepatic ducts. And these ducts are going to be supplying and draining products that come from the liver. So as you're making bile, they're going to go in the ducts and kind of channel into larger and larger ducts. And I'm going to flip back a couple slides here. And eventually those ducts drain into these larger and larger conduits, so they can eventually make it into your duodenum. So we see them as these little teeny tiny ducts, green in that picture, and they essentially wrap around every single hepatocyte or liver cell to pick up secretory products that your body's going to need. So jaundice in general is basically buildup of bilirubin in your body. And it also causes changes in stools. So we've talked about all three types of jaundice, but basically how are they caused? Prehepatic jaundice is caused by an unconjugated bilirubin. So this is bilirubin that's not undergone any changes and it just builds up. Intrahepatic jaundice, remember, this is where the actual liver is being destroyed, is both unconjugated bilirubin and conjugated. Once it's conjugated, it's marked for removal. So this is both, active and old bilirubin, and both levels are being elevated in the body. And post-hepatic jaundice, remember, this is going to be caused from blockages outside the liver. You're going to see just the end stage, the breakdown bilirubin is being elevated in the body. And this can actually cause your stools to become really, really light in color. So almost even a white or a chalky color. This is really dangerous, and this is when you should seek medical attention quickly. So kind of switching from jaundice, but still talking about the liver, the next disorder we're going to talk about is hepatitis. There's 5 kinds of hepatitis. Hepatitis is essentially inflammation of the liver. It can be caused by alcoholism. It can be caused for unknown reasons that maybe are genetic or maybe just kind of spring up for things that we just can't figure out medically. It's called idiopathic. And quite often it leads to fatty liver disease, where the liver just becomes encased in high amounts of adipose. And then there's viral hepatitis that we're going to spend a lot of time talking about in the next couple slides. And there's specialized local infections that can either be self-limiting or chronic, depending on the viral strain that infects it. So viral hepatitis is going to cause inflammation, swelling, pain, and most importantly, necrosis. Remember, necrosis is the big, ugly cell death. It's when cells basically explode and release all of their contents outwards, and they damage nearby cells, causing them to explode in ugly ways as well. So there's 5 different viruses, Hep A, B, C, D, and E, and we're going to go through each of them. They're all important. You do need to know each of the 5. So hepatitis A is called infectious hepatitis. And hepatitis A is quite often transmitted through the fecal-oral route. So people who aren't participating in adequate hand washing. So remember, it's that 20 seconds of hand washing followed by a good hearty rinse. So I used to work at Wayne State in the School of Pharmacy when I did the neurochemistry research. and we were directly across the street from a Whole Foods. And this happened after I had left Wayne State, but I remember getting an email that basically said that if you have eaten at the food bar at this Whole Foods, you could go to the DMC and get a free vaccine for hepatitis A because somebody at Whole Foods had Hep A. So this is not every Whole Foods. I'm not trying to kill their business. This just happened to be at Wayne State. This was a number of years after I had already left. I just had a friend who was still in school, and I had still was receiving the emails, and she told me, and she was pretty nervous because she got lunch there every day. So again, it's transmitted oral fecal route, but here's the good news about Hep A. So it's painful, it's swelling, you do get some necrotic death, it can cause long-term damage, but the good news is it's self-limiting. There's no carrier state. You get the infection and it heals eventually, and you heal as a person eventually. It doesn't go into a permanent state. Hep B, on the other hand, is permanent. It goes into a carrier state. So about half the people who have Hep B don't even know it because they don't display a lot of symptoms. So that being said, Hep B is easy to transmit patient to patient. So it can be transmitted via infected blood, so sharing of needles, or sexual transmission. There are vaccines available and they're routinely given to kids. I think it's a shot and 2 boosters. I can't remember. I know my son has had the vaccine. I got the vaccine when I was a teenager because it didn't come out till I was a teenager. This is a relatively new vaccine. And I remember having to get it in an initial shot plus 2 boosters, but I don't know if they've changed it or increased the efficacy since. It's been a long time since I've been a teenager, guys. Hep C is also can exist in a carrier state. So it is permanent, it is for life, it is something that somebody can always pass on, and it's usually transmitted via blood transfusion, sharing of needles, although it can be sexually transmitted as well. So people who have Hep C are at a greater risk for liver cancer, although it is not a guarantee that somebody will get Hep C. Some common people who have Hep C that you may have heard of, Pamela Anderson has hepatitis C, and I can't remember which, is it Tommy Lee? Was that the one husband of hers that had it? But I know that they do have Hep C. All right, hepatitis D is fascinating. Hepatitis D you cannot get unless you already have hepatitis B. You can have hepatitis B and never get D, but you can't get D unless you already have B. So D is considered an incomplete virus. So it doesn't have everything it needs to be a fully infectious virus, but it can kind of steal what it needs from hepatitis B. So that's why they work together. And hepatitis D is a blood-to-blood transfusion. So again, needles or sexual transmission. Hepatitis E is not fully understood. It's a lot less common. It's not chronic. There's no carrier state, so it is self-limiting and a patient does heal, but it's pretty idiopathic. Like, it is virally transmitted person to person, but it's a lot less common and we just don't know as much medically about it. All right, so those are the viral types. Now let's kind of talk about signs and symptoms, diagnosis, and treatment. So there's 3 main stages of hepatitis. There's pre-esoteric, esoteric, and post-esoteric. So pre-esoteric is when it's developing. It's prodromal. A patient doesn't know that they have it. They're tired. They feel like garbage. They might not want to eat, or they might be nauseous. They might just have general aches and pains, but it's easily dismissible and they just don't know. The esoteric stage is the full-blown infection. This is where the patient's really in agony and really suffering. So a patient can develop jaundice, which then, because of bilirubin, can drive those stools really light in color, that white chalky, and which is an indication of liver damage, and the urine can get almost brown in color. The liver is really, really tender, so that means that your upper abdominal region is going to be really sore to the touch, because of how big and swollen the liver really is. The post-esoteric stage is when the patient's recovering. So all of the signs and symptoms that we've just talked about start to alleviate little by little by little. This can last for weeks or even a month. So this is a typical course of how Hep B works. Remember, Hep B, a person gets an acute infection, it gets highly inflamed and irritated, but then it kind of subsides. and goes away. And then it goes into a chronic state where it's relapsing and remitting. They might not show symptoms for like a year or 5 years, and all of a sudden they'll have a horrible flare up, and then it goes away. And then a horrible flare up, and then it goes away. So the initial acute infection might take 6 to 8 weeks, but then really after that, these flare-ups kind of happen, I don't want to say with no rhyme or reason. They're usually triggered by some sort of stress, whether it's physical, chemical, or psychological. With viral hepatitis, the only defense that you really have is to form antibodies against it, and vaccination seems to be very, very effective. Supportive measures when a person's having a flare-up are just going to be things like rest, keeping a diet that's high in protein and carbohydrates, but very, very low in fat, because you don't want to be having to stress the liver out producing bile. You also want to make sure the person's having adequate vitamins, so they're getting everything that they need to stay healthy. Chronic hepatitis can be treated with interferons. Interferons are kind of like helpers in your immune system that can help attack and destroy viruses. So switching gears, cirrhosis is important to mention because cirrhosis simply is destruction of the liver, and people who have hepatitis can develop cirrhosis. Quite often you see cirrhosis in people who are alcoholics. Chronic alcoholism, alcohol basically gets in and disrupts the hepatocytes. It prevents the phospholipids that make the hepatic cells, it prevents them from being fully functional and having competency. So the cells just kind of fall apart and they die necrotic, ugly deaths. There's different types of cirrhosis. You can have biliary cirrhosis, which is usually happens when someone has an autoimmune disease and their own antibodies are attacking the liver and gallbladder. There's post-necrotic cirrhosis, and this is quite often linked to hepatitis, or if people have been taking high levels of like toxic drugs. There's metabolic cirrhosis, and this is usually having to do with an underlying disorder. You would have some sort of problem that causes an exacerbation or an overworking of your liver. You're kind of working the cells to death, basically. The picture at the bottom is what a cirrhotic liver looks like. So the big issue here is the liver is a regenerative organ. If it gets damaged, it can regenerate. It can kind of repair itself. But as we have learned and talked constantly about, scar tissue is never fully functional tissue. So the liver that you're seeing is full of these like scar tissue necrotic patches that either the cells are in the process of degrading and falling apart, or it's scar tissue of non-functional tissue. You also can get massive pockets of fluid accumulation called ascites that we'll talk about later that are just going to lead to further destruction of the actual liver. Notice the picture that you see here. This is due to hepatitis C, so there's a virus destroying this liver. This really doesn't look like any other stereotypical or hallmark liver that you might just Google what healthy liver looks like. This really resembles nothing of what a healthy liver looks like. You totally get complete disorganization in the liver. Your liver is broken up into 4 main lobules, and they just lose all cohesion and organization and functional symptom. So alcoholic liver disease or fatty liver disease is broken up into 3 main stages. The initial stage, which is called the fatty liver, is where the liver gets really, really big. And it's due to swelling, inflammation, and you're starting to accumulate fat around the liver. So here's the thing. This is asymptomatic. People don't often know they have it at this stage, but it's totally reversible. If a patient who was an alcoholic stopped consuming alcohol, then the liver would likely go back to its normal size and inflammation would go down. The second stage is called alcoholic hepatitis, and you're having mass inflammation. And now here's the point of no return. I'm going to point to it. Oops, sorry about that. Mouse is going crazy. Okay. Cell necrosis right here. Necrotic, ugly death. When cells start to explode and start to destroy the other cells around them, that is the point of no return. The third stage of cirrhosis is called end stage, and this is basically where the liver is barely functioning. It's not producing bile like it should. It's not detoxifying the blood like it should, and the liver just kind of turns into kind of a pile of non-functional sludge. Some things that you see with liver destruction Can't remove bilirubin, so a person's going to develop jaundice. You'll have less production of bile, so we're not going to be able to take fat out of the diet, which can lead to disruptive GI movements, a lot of fatty diarrhea, greasy stools. You will also have decreased ability to produce anything to help you with a blood clot. So somebody who gets a cut or some sort of massive laceration, they'll bleed a lot more than they should. And somebody will also have less ability to regulate their blood glucose levels. So they might start to appear diabetic. All right, some other things that we see, decreased deactivation or breakdown of drugs. We'll see decreased removal of anything toxic. So remember, you have a lot of drugs or other things that you ingest that are cleared through the liver. So alcohol, the part that makes you drunk, is cleared through the liver, and you essentially are going to excrete it out. But again, the more your liver breaks down, the less you'll be able to remove these toxic substances. You won't be producing as much bile, and the bile you do produce could essentially back up in the liver if you're getting destruction of the ducts, the biliary duct or even the cystic ducts. If you're getting backup or destruction of the ducts, then the bile will have nowhere to go and you'll get a back pressure into the liver, which will cause pain. And as much as we haven't talked about the spleen, if you start to destroy the liver and the spleen work really, really well together. Especially for red blood cell turnover. If you are starting to destroy the liver, the spleen is going to try and pick up the vast majority of the bulk of work, but this could cause massive back congestion in the spleen. Another important thing that I think we need to talk about is B12. Remember, intrinsic factor, you have to be able to get B12 in to prevent that hemolytic anemia. So if you can't, if your liver's not functioning the way it should, you will not store iron the way you should. You will not store B12 the way you should, and you will develop anemia as a result. You can also get congestion in the walls of the stomach that would impair digestion and absorption, specifically of the B12. You're going to develop those varices that I talked about, those pockets of fluid accumulation. I'm sorry, varices are going to be your lesions, ascites are the pockets of fluid accumulation. You'll specifically get these all over the peritoneal cavity surrounding your intestines as well as your liver, spleen, and so on. So this is just kind of a course by course progression of how ascites occur. I'll leave this for you to review on your own, although again, I don't necessarily think this is a huge flashcard slide. Cirrhosis in general starts with manifestations that are mild and vague and very easily dismissible. You might just kind of feel like garbage. I'm tired, I'm losing weight, but I'm not eating well. You know, it's really easy to dismiss. It could become a dull and aching pain in the upper right abdominal quadrant, and then a patient's usually going, something's not right here. And then they might seek medical attention. Advanced cirrhosis is the one that's really not reversible, getting the massive ascites, those fluid pockets, and then peripheral edema because you're not clearing and filtering the blood the way you should, so fingers and toes will be really swollen. You'll get those lesions all over the esophagus that could rupture and lead to internal bleeding, and we've already talked about jaundice and encephalopathy to some degree. So this is a review slide. I think that this sums up cirrhosis really well. If you could look at this and kind of tell the story that we've told so far, then you know cirrhosis really in a nutshell. So how is cirrhosis treated? Well, first of all, stop doing the things that make it happen. So again, cirrhosis is a huge concern with alcoholics. So an alcoholic's going to be told, just stop drinking. And I know that's easier said than done because it's an addiction. But alcoholics who stop drinking see massive improvements in liver function and whole life, quality of life. But the hard deal is alcoholism is an addiction. It is a massive problem, both psychologically and physically. So it's a hard habit to break. Diet restrictions can help. So eat things low in fat so you're not challenging the liver to produce as much bile. So this would be good during the treatment phase. And then taking in enough electrolytes, making sure you have building blocks that your body's really going to need. So patients can also undergo a procedure called a paracentesis, and it would basically be pulling like a needle full or an aspirated needle full of fluid from the peritoneal cavity to examine it, just to see, what is in this peritoneal fluid. Do we have leakage of contents into the gut? What's the electrolytes look like? Is there white blood cells? Antibiotics are also really good because at this point you probably are going to be developing infections in your intestines. Emergency treatment usually would be surgical intervention at the level of the esophagus to repair the varices if they rupture. And then liver transplant's always a possibility too, but someone who's an active alcoholic will never be eligible for the liver transplant. They would have to be a recovering alcoholic, or they would have to have, and they would have to be recovered for a significant period of time. Liver transplant would be also somebody who may have had cirrhosis from hepatitis. All right, so again, this is just a review. I don't think that this is anything you need to commit to memory, but I think, again, this just kind of reviews everything we've talked about in a nutshell. All right, so, this mouse is so sensitive. All right, so we are recording. I might not have paused. Well, I'll have to edit the video later then. Lower GI disorders. All right, so chronic inflammatory bowel disease will be the first one that we talk about. So this is Crohn's disease and ulcerative colitis. So they are both considered to be IBDs, inflammatory bowel diseases. Quite often the causes are unknown. There's genetic factors that appear to be involved. So what that means is it really can run in families. Crohn's disease and ulcerative colitis, we're going to spend some time talking about. The difference in diagnosis is that Crohn's quite often is diagnosed in adolescence. Doesn't mean it has to be, but most common, where ulcerative colitis is quite not often diagnosed until someone's in their 20s or 30s. There's a lot of similarities between them, but there's a couple key differences. So I'm going to put this here now as something that I think you should go back to. We're going to spend time kind of talking about these points in the next few slides, but this really sums up a lot of the differences. All right, so Crohn's disease. So it can affect anywhere in the digestive tract. However, most often it affects the small intestine. So people with Crohn's disease often develop something called skip lesions. So what that means is there's an affected area that's inflamed and has a lot of necrotic cell death, but then there's totally normal healthy tissue. And then there is a region that's infected again or inflamed, and then there's normal tissue. And it seems to happen in these like spotty patches. Crohn's disease is really a progressive inflammation and fibrosis. So you have cellular destruction, regeneration, destruction, regeneration, destruction, regeneration, leading to this chronic fibrotic state. So Crohn's disease, you often see an interference with digestion and absorption. What this means is because of all the fibrotic tissue, you're not going to be absorbing the nutrients that you need. You also are going to be struggling with being able to absorb as all of the transporters in the small intestine are getting damaged by this destruction and then scar tissue, destruction, scar tissue. The transporters get wiped out so you don't take in the nutrients that you need. So quite often people can lead to hypoproteinemia. They're not taking in protein. Avitaminosis, they can't absorb vitamins. Just general malnutrition. And they develop something called steatorrhea, which is a very oily stool. So it's really greasy diarrhea, which basically happens because they're unable to absorb the chylomicrons that are basically the emulsified fat by the bile. Other complications that can happen are something called adhesions. So you end up with two sections of small intestine, for example, that get highly destroyed from the flare-up and the inflammation. And then as they heal, they actually start to heal together. They shouldn't, but they start to kind of like stick together, and they turn into like one like massive area of tissue, like a lump of tissue, as opposed to being two distinct sections of a small intestine. Kids who have Crohn's disease quite often see delayed growth and sexual maturation simply due to the chronic malnutrition. All right, so this is a small intestine of somebody with Crohn's disease. You can see that so here, for example, this is some scar tissue. You see fibrotic tissue here. You also see areas of high inflammation. You can just see how much blood is present from just the increased blood to the area and the generalized swelling. Ulcerative colitis, on the other hand, starts in the rectum. So remember, back here with Crohn's disease, it can affect anywhere, but it's largely small intestine, where ulcerative colitis is mainly in the rectum. So it can progress backwards up through the colon. You tend to see the mucosal and the submucosal layer have massive inflammation. You see lots and lots of tissue destruction, and here a person is not going to see the absorption of fluid. Remember, water is absorbed in the large intestine, where nutrients are absorbed in the small intestine. So ulcerative colitis, or UC, tends to occur episodically. So a person will have an inflammation episode where it gets really, there's a lot of colon inflammation. They get toxic megacolon. They get huge bouts of diarrhea. They can have diarrhea stools anywhere from like 8 to 12 times a day. Their stool can be very oily. It'll have lots of blood and mucus, and will have massive bloating and cramping as well. This is a colon in panel A that's healthy. So this person has undergone a colonoscopy. There's a camera being inserted up the rectum and into the colon to look, and you see that it's clean, it's smooth, it's shiny from mucus, but this colon has no polyps, there's no inflammation. It's just, it looks like healthy tissue. The one in panel B is high degree of inflammation. Notice the diameter is reduced. All the red is from the excessive blood, and you start to see these dark patches of internal bleeding that's starting to scab over. Diverticulitis, on the other hand, is different. Diverticulitis is really defined as the development of diverticula. Well, what does that even mean? A diverticulum is singular, where diverticula is plural, and it's basically this outpouching, or these little like patches of pockets that develop all over the colon. And I'll show you a picture of this in a minute. So it's herniation, or just kind of gaps in the mucosal layer. And there's two different things that can happen: diverticulosis and diverticulitis. Someone who develops diverticula are going to maybe start out with diverticulosis, it being asymptomatic, where they don't even know that they have it. My second husband had this, and we didn't actually even know until he had an umbilical hernia, and then he went in for a CT and noticed he had diverticulosis. Diverticulitis happens when someone has diverticulosis. It's where the diverticula get inflamed, and they start to cause cramping, they cause pain, they cause bloating, a lot of inflammation and irritation in the area. So I'll show you a picture here in a moment, but basically, again, you're getting these little like rips in the muscular layer, and you get these little tissue outpouchings where food and fecal matter can actually get stuck, bacteria as well. So, and the problem is when the bacteria and the food get stuck in these little pouches, they release a lot of enzymes, and the bacteria can release toxic substances that build up and cause the inflammation and irritation. So I already mentioned that diverticulosis is asymptomatic, and people don't know until they have the inflammation. Diverticulitis stasis is basically when you have the fecal matter get stuck in these little outpouchings, where it starts to really cause the inflammation as the enzymes and the bacterial byproducts start to really cause the destruction of the tissue. So a person will have cramping and tenderness. They might want to throw up. They might run a slight fever. We're not talking massive fever, a low-grade fever, and their white count will probably be higher as well when they've gone from diverticulosis to diverticulitis. Typical treatment is antibiotics to reduce the symptoms, and then diet modification to avoid things that are going to cause the flare-up. So this is what diverticula look like. It's really, I only put 4 arrows on here. This is a picture I added the arrows to, but it's all of these little pockets through here. This and all of these little pouches that you see. It's just kind of these ruptures or gaps in the muscle layer causing the pockets to form. So, and this would be the lumen here, and this would be the pocket that's forming, and this would be another pocket over here. So as you get fecal matter and food content stuck in here. So the big thing is people who have diverticulitis have to avoid things that can get stuck in the pouches, like nuts and seeds, some berries, corn, things like that are going to cause flare-ups if these things get caught in the pouches. All right, so switching gears, talking about colorectal cancer. Colorectal cancer is malignant, and it is a cancer that develops from little tiny growths called polyps. Polyps are just extra masses of colon tissue that become malignant, and the risk is metastatic. So early diagnosis is crucial because it's a highly metastatic cancer when it finally does, or if it finally does develop. It typically is going to develop in people who are 50 and older, although if there is a genetic, there is genetic underpinnings that aren't fully understood. So if colon cancer runs in families, it's important to get those colonoscopies done at a young age. So I mentioned at the very beginning that I have GI struggles. My GI, I have massive diet modifications that I've had to make. I have a very unpleasant GI tract. I don't have Crohn's or UC, but I do struggle to digest certain materials. I don't digest fat very well, and my GI tract moves very, very slowly. So I definitely try to stay on top of diet modifications, and I try to be aware of family history. Colon cancer does run in my family, and I had my very first colonoscopy in my 30s. And it's not necessarily anything to be proud of. I just mention it because being aware of family history is really important because it seems to run generation to generation. So some signs and symptoms, changes in bowel habits. If somebody has normal bowel habits and suddenly they have massive constipation, or they develop something called ribbon stools. Ribbon stools are when the bowel movements become very long and stringy. And that's usually because there's an obstruction or a blockage preventing the normal stool to be expelled from the body. If there's internal bleeding that's going into the stool, again, the stool will become that very, very dark black color. They can send stool samples back to laboratories for diagnostics. People who are tired all the time, losing weight, or chronic anemia, these can be signs. But if you notice, these are signs of a lot of other things as well. So again, that early screening really is key. Treatment typically is surgery. Pull the colon out. Sometimes it's followed with chemo and radiation. They're both pretty common. Sometimes it's surgery followed by radiation or surgery followed by chemo, depending on how widespread the cancer is. So different places that colon cancer can occur, so you can get it in the rectum, and this would lead to a more solid stool simply because you're compressing the rectum and you're not allowing expulsion of that fecal matter. So if it happens in the descending colon or the descending large intestine, so your sigmoid's here, and this is the descending, again, it's going to lead to constipation. So if it if there's a tumor in the transverse colon, this may not cause massive constipation. It might actually lead to a little bit of diarrhea. So it really, if there's a tumor here, it's going to be a semi-solid stool, but here is where we're definitely going to be looking for blood in the stool. If it happens in the ascending colon, quite often the stool is going to be a lot more liquidy. So just because, remember, the stool that's being sent from the small intestine to the large intestine, it's really going to get blocked before it can travel, too much further. So quite often you can palpate masses if tumors are big enough, or really the colonoscopy is a big indicator along with blood tests. So this is what colorectal cancer looks like. This is, see here the circumferential growth. So basically it's called a stricture. It's a blockage. You're taking this, this is part of the colon, and the tumor growth has grown kind of around in a circle, and you can see that you're really blocking passage of stool through the colon. But what's interesting, so if this is the more distal end and this is more proximal, look how much distension you're getting because of all the stool that's building up in this region. It's causing this to distend and stretch outwards because you can't pass it through. Intestinal obstructions in general can happen anywhere, large or small intestine, but obstructions that are not cancerous are more common in the small intestine than the large intestine. They can be from tumors, adhesions, where two sections grow together, a hernia, or something else, maybe somebody swallowed something that's blocking passage. So people can have functional or adynamic obstructions, and basically this is from motor impairment via the nervous system. So impairment of peristalsis. So your parasympathetics aren't going to be functioning properly and you can't propel movements the way you should. So masses just kind of sit in place. All right, so these are different types of obstructions and different things that can cause them. So hernias here in panel A can cause obstructions. You can also get something called a volvus, where you essentially are going to have blood vessels become compressed because it's sometimes called a tummy twist. So this here, this is not a stomach. This is a section of intestine. The small intestine twisted on itself, kind of like you're curling around a hair tie. And this is all small intestine that's being built up full of liquid and pressure and developing chyme, or developing fecal matter from the chyme. So this is an intussipation. So basically what's happening here is you get the telescoping of the ileum inside the adjacent section of a colon. So you basically get the colon is being shoved up into that last section of the small intestine, and you see so you're having matter that's going to be trapped on each side, and you're having a very narrow passageway in which you're allowing flow from one into the other. So tumors are going to grow and suppress. And then you could also have, this is a diverticula pouch that could fill with fecal matter and essentially get large and plays like a stricture and preventing passage of material through the large intestine. So the big thing with intestinal obstruction is you're going to get gas backup, fluid backup, and fecal matter backup, and that can cause an increase in pressure. And the big risk is explosion, essentially. And you would then release all of those contents out into the gut. So, and that's a big, I want to say gut, I mean peritoneal cavity. Then you risk basically contamination of a sterile environment in your body. Also, the bigger these blockages become, you're going to compress blood vessels and decrease blood supply, and you possibly could have ischemia to a more distal site after wherever the blockage is. Intestinal distension is going to be dangerous as well. Remember, because the more proximal location to the blockage is going to swell and back up full of material. This could lead to vomit. So if you can't push material through forward, it's going to come backwards. And this can cause fluid loss. It can disrupt your electrolyte balance in your body. It can really decrease your overall blood supply due to hypovolemia. So you would reduce serum. Also, this type of blockage could lead to ischemia. Remember, not enough oxygen supply, and it would cause that necrotic, ugly death. So ischemia necrosis is especially dangerous because it's going to kill off the nerve supply, and those nerves might be supplying other regions as well, so you would get massive tissue death. So the big problem with obstruction, I said it 3 times now, another big problem with obstruction is the bacteria that lives in your gut. The bacteria that lives in your gut should be normal and healthy, but if it can't be cleared, or if for other stressful reasons it's activated to become pathogenic, which sometimes can happen, it's called being an opportunistic bacterium, it can then start to release toxic substances that can cause more necrotic death or make you ill on a larger basis, being septic. So some other functional obstructions or something called paralytic ileus can come from surgery. So this would be surgery where you get an adhesion that would come afterwards. So an inappropriate healing from surgery. People having spinal cord injuries could affect parasympathetic innervation. General inflammation, like if people have inflammatory disorders. Pancreatitis can lead to obstructions. Peritonitis, or just general infection in the abdominal cavity could compress anything along the small or large intestine. Let's see here. Mechanical obstructions, once again, from adhesions, hernias. We've already talked about this in the picture. I'll try to get through this quickly for you. Masses, tumors, or again, foreign bodies. There's always a worry, kids swallowing random things. Yes, it's a choking hazard, but it can also plug up their very small intestines. So if you get a mechanical obstruction in the small intestine, it turns into, you get massive abdominal pain. So bowel sounds, all the gases bubbling, normally that we would hear can still be heard, but obstruction in the large intestine, some of those noises go away. If your small intestine becomes blocked, this is a true medical emergency because your small intestines, where all those nutrients are being absorbed, your small intestine is the longer one. Your small intestine's closer to your stomach. That's going to really prevent, more chyme from going in, and you'll have backup into the stomach. So also, because the small intestine is where all the nutrient absorption happens, you won't get any of the nutrients you're eating. You will go into an instant state of malnutrition, and this could kill off really any cell in your body that doesn't get the nutrients that it needs. So medical intervention for a small intestine obstruction is immediate and necessary. Large intestine obstruction generally develops very, very slowly. Often people don't know until it's more severe. It usually starts with constipation. The abdominal pain will follow. The abdomen will get big and bloated, and a person won't want to eat. They might start to throw up, but again, it's much more gradual. Surgery is a very common treatment, once again, followed by antimicrobials. So again, just because of any infection that is taking place. So that is going to wrap us for the day. This just kind of goes over everything I've talked about. This would be a great study flashcard slide. And I thank you guys for tuning in.